two.
Which is not the correct way of managing doing the biopsy and this. So ultimately, it is this portion of salmon colored mucosa you should take the biopsy. After that, the reports of Barrett's have started decreasing. So you have there is a Prague criteria in which there is a longitudinal length and circumferential length from the incisor. You have to calculate both of these and give a report when you are doing a Barrett's esophagus.
Listed here. If you understand this, and accordingly our papers are there, and also the proper communication, proper medical advice, then the chances of the rejection is quite less. The second pitfall is that we are not understand the health policy itself. In the policy there are various types. It's not that a single policy. We have various types, that is individual policy where the rejection rates are higher because of various chances. Then there are family policies where the entire family is covered. Then there are group insurance policies for the group. Then there are corporate health policy where rejection rate is quite high because the corporates have tied up, and also the waiting period here may not be very much applicable. We should understand that when the patients port their insurance from one company to another, there should not be any break, and it should be continuous for 4 years. Minimum is 4 years continuous, because obesity is considered as a pre-existing disease. Sometimes we have to look at what the patient has declared their weight when they have purchased the policy. They may say normal weight, but the next year they come and claim with the super obese weight, then the insurance company will reject. The upper limit of the policy, that's also important when we are doing the obesity surgery, which costs much more than the normal surgeries. The pitfall number 3 is the most worrying thing, that is the inadequate documentation of our first consultation. This is what the insurance companies look very carefully. So when you document the first consultation, you should be very careful that you write properly so that there should not be no scope for any of the rejection. Proper history and also the comorbidities, whether it is hypertension, diabetes, sleep apnea, all the things should be correctly mentioned with the years and also what medicines they are taking, and past surgery, anything they have undergone. Many of the patients hide their past surgery and some of the history, and also the diet habits, whether the patient have proper diet and what the diet they have taken, and the weight loss attempts. This also the insurance companies look at whether the patient has tried enough with all the available methods so that still the weight loss is not there. And again, examination, height, weight, and also the proper BMI, and what is your final suggestion. So this is what the medical consultation is. So you have suggested laparoscopic surgery for the weight loss without a proper evaluation. So this forms the basis, foundation for the surgery which can be approved by the insurance companies later. Sometimes the insurance companies find out there is false documentation. They have their own ways of finding it out. So we have to be very careful that do not do any false documentation of the BMI or the comorbidities or the past history and surgery. So some of the stalwarts like Manish Khaitan, he takes from the patient a written or documentation that his BMI is so much. He has a fixed form, and there all the burden goes to the patient and not to the surgeon if there is any false documentation or the false claim by the patient. The pitfall number 5 is not giving attention to the waiting period clause. See, it started in 2020. When the 2024 over, there will be no waiting period clause at all. If they have taken the patient has taken the insurance before 2020. Pre-existing disease exclusion period is 48 months. So if the patient has taken a insurance 6 months before or for 2 years before, it may not be covered. So we have to be carefully look into the waiting period clause in the insurance policy. Of course, this may not be so strict for the corporate patients and the group insurance patients. Pitfall number 6 is that now the insurance has come, we can charge any amount. So this is another problem with all of us, that irrational charging. Charge very heavily surgeon's fees and the inflated bill. So insurance companies are not there to give sanction for such claims. They will be always monitoring what's happening in the rest of the country and how much a surgery is being cost, whether it is sleeve or the bypass. So insurance companies are also coming up with standard and rational charging agreement with most of the hospitals. This is going to come, so we have to be very careful about our charging also. The next pitfall, that when all conditions are met and still the insurance company is rejecting, so it is very important that we give a complaint. Complaining whom? There are, in the website itself, there is grievances port. You can see in the insurance grievances redressal system, every company, whether it's National Health Insurance, Star Health Insurance, they have a national redressal system. It can be state-wise also, it can be zone-wise also. Please go into that, tell your insurance person at the hospital, they can complain. Because once it is entered in the complaint, it will be monitored by the IRDA, and all the complaints, if there are more and more about another one insurance companies, they will definitely take action. You can also complain to the Ombudsman and the IRDA also. The last pitfall I feel is that whenever there is a problem, not contacting OSSI cell or insurance. Our OSSI is doing excellent work under the leadership of this man, Dr. Manish Khaitan. Whenever you have problem, you just give a call to him. He will, most of the time, he will analyze and also give you suggestions how to come over it. And if it is not possible, definitely he can tell this is not the case for insurance. I am sure when I have completed this, you have
obesity. We know they have a poor quality of life. The evidence consistently shows us this. They've been subject to stigma in areas such as education.
Diabetic for 4 years. HbA1c is 8.5. Again, try.
See, this one we received on behalf of OSSICON 23. On behalf of OSSI, I would like to honor
a difficult area where you saying, for example, example, if you have a cancer rectum, you're sending it to the oncologist, new adjuvant therapy, you're waiting for 2 months. But here we are not ready to wait for too long. How many in
questionnaire that was sent out to all the respondents who were included through an online
in 2003 by Dr. Dorepal, and I was fortunate enough and had an opportunity to attend. We again had it in Mumbai in 2015, organized by Dr. Raman Goyal, where I served as the organizing secretary.
And with the maximum shots, the most shawl.
Understand that it is the people who are actually going to drive this technology. Yes, technology is very good, but there has to be some kind of a brain, human brain behind it. So the first of these, obviously, we have one single visible mucosal fold, which means the stomach is absolutely completely distended just with this one balloon. And we know that that is not the purpose of the balloon. It is only supposed to occupy a small space and not the entire space of your stomach. So obviously we knew that now we have to just puncture this balloon and try to suction it. But like I mentioned, this is made of polyurethane. It is not so easy to puncture. It's actually very soft and very pliable. So we had to make multiple breaks, but it was getting decompressed very, very slowly. So we tried with a lot of methods. We
postprandial hyperplasia, dumping. Yes. Dumping is actually, the total gastrectomy is a routine procedure for this.
So that's what we did this, and we wanted what all else.
Just the question is putting it
That's what we.
Yeah, I think those are all reasonable solutions, but I think this is a very commendable case to present because it's a very tough complication and they've handled it. And I think in retrospect, we could have done a lot of other things, but thank you, Mama, for presenting.
It was such a bulky and fragile liver that we injured at 2 places. We lacerated.
Let's make it a little broader. Let's speak about research in general.
As we just talked about, there's an increased blood-brain barrier permeability, which would eventually result in increased cytokine production and increased macrophage infiltration. Interestingly, the tight junction permeability of blood-brain barrier,
which is associated more with neuroglycopenia, and in these patients, you definitely need to document that this patient classically is suffering from what we call as the Whipple's.
We can see that the vitamin D levels improved.
It's a cornerstone of management, if I'm allowed to say that. Replace simple carbs with complex carbs. try to explain to your patient that you cannot have liquids along with your food. And it is also, there's some studies which show that also soluble cornstarch does make a difference, and it can be used in these patients with reasonably good results, but again not great data out there. But the most important thing is replace your simple carbs with complex carbs. Acarbose, we use a lot of it in clinical practice, reasonably good results with acarbose. Only issue is tolerance, which we all know GI tolerance is an issue with acarbose. Diazoxide we have used in some patients where we had difficulty in controlling with acarbose, 50 milligram twice a day or 50 milligram, 100 milligram twice a day. Somatostatin analogs, again, octreotide is something which we again have used in clinical practice in patients who are resistant to therapy. The biggest issue with octreotide is that patients get resistant to octreotide after 4 to 6 months, and the daily injections, which are thrice a day post meals. And the other issue is that subsequently when you shifted them to lanreotide also, we've not had very, very encouraging results. So that's the avexitide trial for you over here. Again, a phase 2 trial. I thought it's important to bring it up over here in this audience, so that's why I put it up here. Good results, not significant amount of hyperglycemia. I won't talk about surgical interventions to this audience. I mean, in a nutshell, what I've just spoken to you about, yes, document the diagnosis, be sure that it is the right diagnosis, modify diet, teach the patient how to correct hypoglycemia, teach the patient, educate not only the patient, the entire family, very important when they find any kind of altered behavior, medical line of therapy if required, surgical line of therapy including feeding through a gastrostomy tube, and of course the other surgical interventions.
There are a lot of changes happen when the patient becomes obese. There are endocrine changes, metabolic changes, adipose tissue dysfunction, mental dysfunctions, and cardiovascular. So multi-system problems occurs when the patient has got obesity, and it is not only a aesthetic purpose that the weight loss, which initially people thought and people did it for that particular purpose, which happened with other SCPs. Okay, we should ask patient to go for or bariatric surgery. When we talk in terms of gut hormones, I remember
to treat these patients with laparoscopic sleeve gastrectomy, in which bypass is not an option. So there are a lot of mechanisms.
Was diagnosed with diabetes mellitus in 2013. She was on insulin initially, and then later on she was on OHA. Asthmatic, obstructive sleep apnea on sleeping pills. She also had this.
Why sleeve is preferred in all patients who are candidate for transplant.
Behavior of a patient with respect to their food and lifestyle management. So psychological adaptation of a patient with post-bariatric diet and lifestyle modification is playing a major role in a long-term success rate of bariatric surgery. So pre-bariatric psychological assessment is coming pictured here, and it is a need of the hour.
That it should be more than or equal to 40 or the greater than 35 with
or the baseline BMI. Now there are biological mechanisms which link obesity to cancer. These include high levels of circulating estrogens, high leptin levels. There are pro-inflammatory adipokines. There is a pro-inflammatory state where there is raised insulin levels, raised insulin-like growth factors, a high incidence of type 2 diabetes. There are inflammatory markers like interleukin-1, 6, 8, tumor necrosis alpha factor, and there are certain epigenetic changes, something which was mentioned in the oration yesterday, that is the telomeres which shorten. All of these create a pro-neoplastic state. There is increased mitosis, increased cellular proliferation, increased cellular migration, angiogenesis, and reduced cellular apoptosis. In addition, there are mechanical mechanisms too, such as excessive deposition of fat at the esophageal junction, which disrupts the anti-reflux mechanism, causing an increased incidence of gastroesophageal reflux disease, Barrett's, and esophageal adenocarcinoma. Now, this is a systematic review of more than 200